Okay. Who thinks they know something about Alzheimer's? Raise your hand. Raise them high, I want to see. Okay. Is Alzheimer's the same thing as dementia? Okay. All right. We're starting off on the right foot, I think. Okay, so the purpose of this talk today is to try to familiarize you with what's really supposed to be, I think this is what I'm using. Anyway, try to familiarize you with what's actually true about and true in the field of Alzheimer's care and dementia, and to try to make us all more aware of the opportunities to improve outcomes. Now, why is that important? I guess for the most part in recent history, there really haven't been many alternatives for the management or the treatment of Alzheimer's. There still isn't, but we have some hope and some opportunities where we can take advantage of certain research that's going on here in Atlanta that may be a benefit to some people, maybe not all people, but to some people. Latrice, is this the thing I'm supposed to use that advances the slides?
No, you'll probably just have to use your
Okay.
space bar, probably the best way.
Okay, that'll be fine. Okay, so what are we going to do today? We're going to try to define and recognize certain features of brain dysfunction or dementia. We're going to try to become more knowledgeable about the importance of clinical research participation by women and all ethnic persons. We're going to try to understand the connection between good cardiovascular health and maintaining brain health, because there is a strong connection. We're going to try to describe and address disturbing behaviors of dementia. So, what are some of the common questions that physicians and clinicians get asked? What's the difference between normal aging and abnormal cognitive aging? Are Alzheimer's and dementia the same thing? What's mild cognitive impairment? Why is it important? And how do we know it's Alzheimer's disease? What can we do to treat it? And can we prevent or reduce the risk of Alzheimer's? So I think for the purpose of this talk, every time you hear Alzheimer's, I don't want you to fixate so much on just Alzheimer's. I just want you to think of dementia in general, okay? So wherever you see Alzheimer's, except for when I start talking about pathology, substitute any other type of dementia for Alzheimer's, okay? So why is this important? Because it's an epidemic. It's an epidemic because we're living longer and we're seeing more and more people over the age of 65 afflicted or affected by some type of dementia. 3% of the population between age 65 and 74 may have some cognitive impairment. 75 to 84, this is like 19 to 20%. And nearly 50% of those persons over the age of 85 have some features consistent with Alzheimer's disease. The rate of persons being diagnosed with this is going to incrementally increase. Why is that? Is it that we're getting more demented as we age? No, because we have a greater population that's living longer, and you're going to run into it more often. It's very important for you to understand that Alzheimer's disease and other related dementias are the most expensive chronic disease in the entire world. Why? Okay? More expensive than Parkinson's, prostate, breast cancer, stroke, hypertension, heart disease, cancer, and diabetes. Why? Because there are a whole lot of features that go into this cost. Most of the cost for caring for persons with dementia is borne by Medicare and Medicaid. Those are federally funded governmental programs, which means taxpayers pay for it. So what you want to do is reduce the cost of managing people with this disease. An example of that from my perspective is unnecessary and too frequent use of the emergency room for managing persons who have a dementing illness. People with dementia can't tell you they have a urinary tract infection. They can't tell you that it burns. So they get delirious and demented and you rush them to the emergency room. They get dehydrated, they pass out, we call 911. We spend 8 to 12 hours in the emergency room. We may or may not get a liter of fluids, but then they get sent right back home and then the same thing happens all over again because the family doesn't understand why it happened in the first place, right? So we want to take care of this. It's also hard to treat persons with dementia because of their inability to communicate with you. Why is this important for Georgia? Well, estimates are we have about 120,000 persons in the state of Georgia who've actually been given a diagnosis of dementia. Through the Georgia Alzheimer's and Related Diseases State Plan, we think this estimate is really pretty low, more closer to about 500,000. Why? Because most people aren't diagnosed with it. Okay? On this particular map, this area where you see blue is the area where you have the highest prevalence of Alzheimer's disease and dementia in the state of Georgia. So that's southeast, southwest Georgia, except for up here in the city of, in DeKalb County, not city, the county of DeKalb County. That's the next highest density where the highest prevalence of Alzheimer's exists. So that's kind of like our metropolitan area. But down here in South Georgia, this is an important thing because there are a couple of reasons. I mean, these are all statistics from the Georgia Department of Health. This is also one of the poorest areas in the state of Georgia. There are few primary care doctors. There are even fewer subspecialty doctors to help manage people with these kinds of diseases. So what about Georgia Medicare beneficiaries? 50% of all Medicare recipients over the age of 65 may have an Alzheimer's disease or related dementia. 92% of those persons with Alzheimer's disease or related dementias have at least one chronic disease. Persons with a diagnosis of Alzheimer's disease and related dementia have at least 4 out of 10 chronic diseases. So remember I said, think about the correlation between cardiovascular disease and brain health. Let's look at these chronic diseases. What are they? High blood pressure, we know about high blood pressure, right? We're all willing to talk about our high blood pressure. Well, the high blood pressure does something to your brain. Okay, diabetes, hyperlipidemia, heart disease, chronic kidney disease, anemia, rheumatoid arthritis, depression, COPD, and heart failure. Of those chronic diseases, those of us who are managing patients with chronic diseases and practicing preventive health care, we know that many of those things are preventable, right? 20% of those persons who don't have Alzheimer's or related dementia may have one chronic comorbidity. Okay, so what else is important about persons with dementia? I want you to pay attention to the green stripe. The green stripe is the death rate for people with Alzheimer's and related dementias. I will tell you that the death rate for women with this disorder is higher regardless of what your ethnicity is. The take-home point is that women with dementia, regardless of their ethnicity, are at a higher risk for dying from all kinds of reasons. So what is dementia? Is it normal? Nah, it's not a normal part of aging. I have patients that have been 103 years old who have normal brain function. Their bodies don't work so well, but their brains are fine, moves a little slower. It's an acquired condition with a decline from a normal baseline. I like to say that your brain and your body should get you where you're going, whether you're 20 or you're 100. But intervening things kind of make that impossible sometimes. And dementia is one of those things that can make it impossible for you to get where you're going. These symptoms of dementia are not temporary. They're not transient. They don't go away. And these behaviors that you may see with people who have dementia and the symptoms of dementia have things that go on such that they can't take care of themselves. This interferes with their ability to manage their activities of daily living. And if they're younger, it may interfere with their ability to maintain a job. We have persons with early onset Alzheimer's in particular who have poor performance ratings, poor performance reviews. And there are people who do have early onset Alzheimer's, and if you get the diagnosis right early enough, quick enough, those persons, rather than being fired, can retire with a disability. There's a big difference. Okay, if you're fired with no benefits, you have no health benefits, you don't have a lot of other things. But if you have early onset Alzheimer's and we can document it and confirm it, you can get a disability and retire with same. And in the workplace, we're trying to recognize that. There are a lot of us who continue to work till we're like 75 and 72. And doctors in particular, they just let us do whatever we want to do until somebody says something. Lawyers too. Lawyers too. It's becoming a problem such that we developed a curriculum for the Georgia Law Professional Association on dementia because there are a lot of judges, a lot of sitting lawyers who have this problem and nobody has stopped them from practicing. They continue to sit on the bench and continue to practice law. Doctors, teachers, people continue to teach until somebody stops them. Okay, so what is it? A definition, deficits in 2 or more higher brain functions. In the industry, we call those domains. So what are some of those domains? Memory. Everybody talks about memory loss, but memory loss comes from a lot of different things, but we don't really worry about too much about memory. Language function, using the right words for the right things, proper use of language. Learned motor skills. About 2 years before most people have a diagnosis of dementia, they start to have problems with the way they ambulate. They may be at increased risk for falls. Visual spatial abilities is my brain interpreting depths and looking at things in the way that they're supposed to. Executive functions. What is an executive function? Again, these are domains. If I learned how to do something as an adult, and if I develop dementia, I've kind of lost my ability to do it. One of my favorite cases was a patient who was an Alcoa aluminum executive. He liked to play golf. He says, I know what you want me to do. My son takes me out to play golf, but I just can't remember how to do it. And his son says he doesn't remember how to do it. But this is something he did all the time. But because of his dementia, he could no longer play golf. If you are a good cook, your grandmother, your mother is a very good cook, and she's made fantastic cakes, fantastic dishes, using with or without a recipe, and she can no longer use or make those favorite dishes anymore. That's a loss of an executive function. You understand that one? So when you hear that? Okay, judgment and problem solving. A lot of people with dementia can't get from point A to point B. They can't solve a problem. They may do weird things. I mean, I say judgment here, but you know, people who enter sweepstakes. You know, I had patients who would come, they enter clearinghouse sweepstakes, they send money off to people, and they're addicted to entering sweepstakes. Weird kinds of things that don't make sense. I won $1 million, and if I send $200 to these people, they'll send me my $1 million. You know, I want a computer, but before I get my computer, I have to send them $100. And I'm like, you didn't win anything. If you want it, they should give it to you. No, I want it. And then when you go back and you investigate, they didn't win anything at all. It was one of those scams. Personality and behavioral changes. This is one of the, I will say, probably one of the more softer signs that indicate that somebody may be developing a dementia. I don't have the slide, but when I say personality, some people may start to get a little nasty. Oh, she's being evil, she's accusing me of stealing, she's being obstreperous, she's not going places. Somebody who used to go to church all the time or be very active in the community no longer wants to go out, wants to just stay home. They are paranoid. Some people develop some paranoid symptoms. People who develop apathy, early signs of depression, it kind of like falls into this category, but those are the things that we don't pay attention to. We get called to see and evaluate people when there's a real problem. We don't mind people who decide they don't want to go out and be sociable, but when those persons come to the door with a shotgun and don't recognize you, we call 911 and we get all concerned. Do you understand what I'm saying here? This is a problem. And this is when we should really start paying attention. So what are some of the risk factors for brain dysfunction? Okay, there are two things up here for which we can do absolutely nothing. If you live long enough and you're blessed to live to 85, 90, or 100, that's good. You got good genetics somewhere. Okay, but most people who get to be that age may have some kind of cognitive impairment, so you need to be a little bit more astute and you need to start looking for it. Genetics, okay, and gender. Most of us can't alter our genetics, and we can't really, well, yeah, we can alter our gender, but let's talk about the genetics, okay? We most commonly talk about ApoE4, but that's just one of the more widely studied or best known genes. In African Americans, there's something called the ABCA7 gene. This turns on the Alzheimer's cascade in the presence of poorly controlled hypertension and cardiovascular disease. It also, that's one of the differences between African Americans and non-African Americans. Again, science and research is showing that there's a predisposition for development of this disease in females, and not just because we happen to live longer, but there may be some hormonal aspects to this that create a predisposition for the development of dementia, Alzheimer's type in women. So if you're over the age of 50 and you're female, we need to start paying attention. Now, why do I say that? Because whatever happens to you in middle age predicts what happens to you at 75 and 80. If you have high blood pressure, if you have diabetes, and you have not been working on controlling it, it has a tendency to control you later on. You know, we develop congestive heart failure because we haven't controlled those things. Okay, stroke and cardiovascular disease. Okay, what's the mechanism? Well, everybody knows that most people who've had major strokes have problems with both their physical function and their cognitive functions, right? So think about what causes strokes. Those are the things that you want to target and be paying attention to. Cardiovascular disease, strokes, cardiovascular disease, these all have to do with your blood vessels, okay? If an end organ is losing blood supply, that means the blood vessels aren't working well, right? Okay, so blood vessels that affect your heart also affect your brain. If you have atherosclerosis and peripheral vascular disease in your legs, you have problems with circulation to your heart, you have problem with circulation to your brain, all right? If the end organ doesn't get enough blood supply, what happens to it? It dies. Okay, so over time, you have all these things I've just talked about, you're going to have an effect up here, all right? Heart disease, we've talked about. Diabetes, why about diabetes? Okay, we know risk factors for diabetes. Well, diabetes accelerates the atherosclerotic process, does it not? Okay, so poorly controlled diabetes, long-standing hypertension, and it's not just I have high blood pressure at 60 or 70, it's the duration. Research is showing that the duration of a hypertension diagnosis has an effect on blood vessels. What happens with high blood pressure and blood vessels? They get more muscular. Again, that shrinks the blood vessel lumen and impairs blood flow to the brain. Head trauma. We've all been hearing about chronic traumatic encephalopathy, football players, boxers, anybody who's playing a contact sport. Head trauma, okay? Toxic substance abuse. I'm going to talk about this one a little bit more because I think that in a certain population, certainly in geriatric patients, we have a tendency to excuse alcohol use. Well, you need to pay attention to that because that creates a lot of other problems. I know that there are patients, and this is a generation, how many of you read the Sisterhood of the Yaya Sisterhood? Okay, what was one of their favorite things to do? They had cocktail parties in the afternoon, right? How many of you watch Mad Men? You don't watch Mad Men in here? They had afternoon cocktail parties, okay? In the 60s and 50s, you entertained at home, and if you were a certain group, you always had a drink, okay? Well, women who, or couples or women who are used to doing that have a tendency to want to continually have a drink with dinner. Only as you get a little older and our judgment gets impaired, 2 fingers becomes a tumbler. I had a patient who was always falling, getting beaten up, and then they finally discovered that she was drunk, okay? She wasn't demented, she was just drunk. And she was drunk because she fell, and she banged up her head and got a laceration, and then she finally admitted that, yeah, maybe I had something to drink. I only had 2 fingers, but her daughter held up a glass like this. She said, well, it's just a tumbler full. Got all indignant and upset. But that's a lot of liquor, right? And you do that on a regular basis, and then they move them to assisted living facilities, and they continue to get them liquor. I'm like, well, how is she getting drunk in the assisted living facility? Well, she's going out and getting it on her own. And I'm like, somebody has to buy it for her. Well, I do. It's a problem. Okay, and drugs. And from the drugs, I'm not talking just recreational drugs. We're hearing a lot about pain medicines and opioid addictions, but a lot of us who are of a certain generation, we think a pill takes care of everything. So we have a tendency to mix our sleeping pills with our pain pills, with our anxiety pills, and combine it with our tumblers full of alcohol, and that creates a problem as well, right? I mean, you're laughing, but this is real life. And it can be funny sometimes, and when you have a relative, you have to find reasons to laugh, but you also have to recognize what a problem is and take steps to remediate it. Okay, nutritional disorders. Part of the evaluation requires that we measure vitamin B, D, and folate levels. Okay, people of color are more likely to have a vitamin D deficiency. I do. So if I want to maintain my brain, I better make sure that I start taking some vitamin D. So is your doctor going to routinely check for vitamin D? No. You got to ask for it. But if you're 65, as part of the annual wellness visit, that's something that we do and we can assess and get paid for. Sleep disorders and sleep apnea. If you've been diagnosed with sleep dysfunction and you've been prescribed a sleep apnea machine or a CPAP, many people don't like to wear it because it makes a lot of noise and it's uncomfortable. But sleep problems create brain problems. You know, we have, when we train doctors, we can't have them work more than 40 hours, not on the books anyway. They go moonlight somewhere and they still make 80 hours a week. But sleep dysfunction is closely correlated with making errors in judgment. And so these are things that we can fix. We can fix sleep disorders, we can fix nutritional disorders, and rule those things out as a cause for having a problem with your brain. What are some of the things that protect your brain? Well, the most important thing that I can say, they say education. Now, why education? I'm going to say all kinds of education. How many in here played music, play an instrument, played piano when they were little? Your moms did well because you laid down a new set of neural tracks, so when you lose one, you got some others to wake up. Okay, if you've got children under the age of 7, they should all take music. They shouldn't play Pop Warner football, they shouldn't play soccer, they shouldn't do anything where there's contact sports. They need to play music. So I'm a very strong believer in that, and there are lots of studies that show that people who have had music lessons have more neural tracks to use and utilize in the event that they lose some of the others. So that's why that's important. Education, because the idea is that people who are better educated are going to do a better job taking care of their own health and less likely to develop some of the chronic diseases that I talked about. So when you see education, you can't say that everybody who doesn't have a college education is going to get Alzheimer's. But I will say, just like with any intelligence test, that a lot of the screening mechanisms and the tests for neuropsych do depend upon your having a certain level of social engagement and education so that you can recognize the animals. You know, I had people look at a rhinoceros and tell me it was a pig. They'd never seen a rhinoceros, so they couldn't tell you that it was a rhinoceros. So she said what she thought it looked like. It looked like a pig to her. So in the screening exam, if she's not got that right, that counts as a mark against her. So her screening exam looks lower than her functional abilities actually attest to. You got me? So if you don't know the word for what it is you're looking at, you're going to get that wrong. And that's why we have to develop tools that are a little bit more universal for people with different languages. Most of the study tools or the screening tools that we use are developed and designed for people whose first language is English. So if you're not a non-English speaking person and that's not your native language, are you going to have a problem with a screening tool? Yeah. Are you going to have a problem with neuropsych testing? Okay, it's cultural diversity. And yeah, they've got dementia in other countries, but most of us don't speak those other languages, so we have to develop something else. Okay, we say anti-inflammatory drugs. Anybody who's at risk for hypertension, heart disease, and strokes needs to be taking an aspirin, including myself. Some people say ibuprofen, vitamin C, and all these antioxidants. Go downstairs, buy a lot of vegetables, you'll get all of your antioxidants. You're living right and breathing right? Statins. For people who are at risk for cardiovascular disease or hypercholesterolemia, we're thinking that statins are important. Why? Yes, it lowers your cholesterol risk, but it kind of does something to stabilize the endothelial lining and kind of preserve blood flow. Red wines, not a whole lot, a drink. All right. Contributors to dementia. What are some of the contributors to dementia? The environment. Okay, keep in mind, what did I say? I want you to take Alzheimer's out and think about all the dementias that I talked about before. Head trauma, depression, hypertension, cholesterol, homocysteine levels. We're not going to test for that. Insurance isn't going to pay for that. They may pay for B12 and folate, diabetes and statins, which I've alluded to before. But your environment does have a lot to do with how you're managing things. Okay. Alzheimer's and related dementias. Dementia is not a normal part of aging. There are several different types of dementia. And I'm going to give this pie chart because I like this one better. It's a more graphic representation. Most of the dementia that's diagnosed in this country has been called Alzheimer's. Maybe 50 to 60% of all diagnosed dementias fall into the Alzheimer's category, followed closely by what we call vascular dementia, or a mixture or combination of Alzheimer's and vascular dementia for all the reasons we've kind of talked about before. And then there are these other dementias up here: Parkinson's disease, frontotemporal disease, Lewy body, CTE is chronic traumatic encephalopathy, HIV, and alcohol. So the broad term is dementia, and there's several different types underneath that. Okay, I like to say that it's a big wheel with a lot of different spokes. So the big wheel is dementia, and you got different spokes. That clear? So when somebody presents with a brain dysfunction and you're not really sure what it is, before you call it Alzheimer's, you got to do due diligence to figure out what's really causing it. Okay, so this is I don't think you can see it. The pathology of Alzheimer's means that you get these clumps of something called amyloid that form in your brain, and they're coupled with something called tau plaques. Well, the way it's sort of like it's an abnormal clumping of proteins in the brain. Research now is such that we want to prevent the clumping of those proteins by preventing the, amyloid precursor protein from cleaving and developing a clump such that our brain doesn't work. So what happens with this clumping, when these protein strands accumulate in the nerve cell dies. And as it dies, the brain starts shrinking and that part of the brain is no longer functional. That's the simplistic answer. But this is, I think this is the only picture that I have. Does this affect this light up here? Okay. Over here on your right is a normal brain. You see all those wormian looking things? You see how the little gaps are kind of close together like your fingers? And on the right side, you have deeper grooves in between your brain. That's what we call brain atrophy. You're going to get that with Alzheimer's, but you're going to get that with any other brain degenerative process. And different parts of the brain are affected differently. In the middle, you have this, you see this thing that looks like a little V? This is supposed to be the areas of the hippocampus. In Alzheimer's, the hippocampus degenerates and it shrinks and it gets very small. And so you see these like big holes of these vacuoles where the hippocampus is supposed to be. Anyway, that's what your picture looks like on autopsy. This isn't normal, but the good thing is that we are developing techniques to look for these kinds of changes in the brain before you die and not on an autopsy table. We do have the capability for this. We have one of 10 such machines in the country. Unfortunately, these machines are only available for these kinds of pictures before you're dead, in vivo, while you're living, only through research. It's not a clinical study that your doctor can refer you to. More about that later. This is an electron microscope slide of the plaques and the tangles, that big glumpy brown thing, that's amyloid plaque. So, now we talked a little bit about Alzheimer's. What's mild cognitive impairment? Well, you're going to hear a lot about mild cognitive impairment, or MCI, which is kind of like the prodromal state of complete dementia. Some people get mild cognitive impairment, and depending upon what's causing it, may progress to Alzheimer's. And some people may just exist there in mild cognitive impairment for forever and forever. Amen. Okay? Most people who have mild cognitive impairment can continue to function, which means they continue to live at home unassisted. They can prepare meals. They can dress themselves. They can take themselves to the bathroom. They can pretty much take care of themselves, and you might need to start helping them with some things. They may have deficits in memory. They may have problems with executive function and language, but for the most part, they can take care of themselves. Their problems don't affect their normal activities, okay? So what are some of the symptoms of dementia, and how do I know? Because I know somebody's going to ask me this. Okay, memory loss is one part. Repetition of words, stories, or phrases. Anybody who's doing things like that doesn't mean that they necessarily have Alzheimer's. It just means that, okay, something's going on. I need to pay closer attention, and I need to get my relative or my patient to somebody who can better evaluate it. Loss of bowel and bladder function. One of the key reasons for people putting their folks in assisted livings and nursing homes is because they've lost the ability to control their bowel and bladder. All of us who have small children know that this is a neurologic function. You have a sensation that you have, or an urge that tells you you have to urinate or that you have to defecate. Well, when you develop dementia, you can't recognize that urge. Okay? I'm not talking about people who can't get up and go to the bathroom and jump up and get there to keep from TTing on themselves. I'm talking about people who just don't recognize the urge, such that they're always soiling themselves in public, and because their children or their caregivers are embarrassed, they bring them to the doctor and say, we got to put her in a home. Okay, that's the number one reason for people to get put in a nursing home, because they're having a problem with this. And this is a lot of care. You have to buy Depends, somebody's soiling themselves, it's a lot of stuff, right? Okay, people who have lost the ability to dress, groom, toilet feed, or otherwise manage their meals and their finances. And I'm going to talk about grooming here. Some people put their clothes on, but they put the same clothes on every single day and they're full of spots and they stink. They don't recognize that they stink. They don't recognize that they have spots on their clothes. If this is a relative or a friend of yours who has never ever been that way, there are some of us who don't believe in chronic hygiene, good hygiene, okay? But there are many people who have lost this ability. And it's like, what am I going to put on? You'll notice that they very carefully put their clothes on the chair because they see them and they can recognize them, and they're going to go back to put those same things on in the morning. Okay, because they've forgotten that they have a closet, they've forgotten that they have a drawer, but they see these and they're going to put them on. And they'll argue with you about taking them off even though they're spotted and they stink. How many of you have a relative who's done that? Okay, and they hate you for it. Okay, gait instability, falls, personality changes, as I've talked about before, and some psychoses that develop. Okay, this particular graph is my picture for really explaining. People say, what stage are they in? Over here on the top, preclinical, we have no problems, and maybe we have mild cognitive impairment. We're still able to function and do like we need to do. With normal aging, there's a line here that's not here. You get kind of like a little slightly lowered slope. That means that those people are functioning well. They're maybe functioning a little slower. They're still taking care of themselves. But as you come down this slope, as you develop worsening dementia, what changes most, other than cognitive ability, is physical ability. Think things like mobility. Think things like getting from, not just mobility, but that's a big thing. Mobility, function, getting around the house and doing things, okay? People, as they progress with dementia, have worse memory, more problems with balance, more problems with gait, may have more problems with falls. Down here between the moderate and severe stage, you know, these people are generally going to be institutionalized within an assisted living if they have the resources, or have 24-hour care. Up here, kind of like at the top of the hill, they may still have some need for supervision. Some families who are super protective may have somebody living with them all the time, may hire somebody to do that, but more often than not, it's some relative who's going to be in the house with them doing most of this. Down here, where somebody has severe dementia, these people are generally not mobile, they're not ambulatory, they're completely unable to manage any of their activities of daily living and need a whole lot of help. Many of these persons with, depending upon where they are and what their resources are, they may be placed in a nursing home. A lot of these people still remain in the community, cared for by whomever is available to do it. And sometimes it's not always a good person. Which brings me to the annual wellness visit. For those of us who are 65 years of age and older, have you had an annual wellness visit? Okay, she's the only one who raised her hand. This is important because this is the Affordable Care Act in action. One of the things we're trying to do with Alzheimer's and dementing disorders is get to the disorder earlier where treatments and other things are available. And it's not just Alzheimer's, but any chronic disease. So we start to have problems when people aren't aware of what they're supposed to have. For those providers in here, it is not a physical exam. It's really a checkoff. Have you done all your preventive health care indices? Have you done your immunizations? Have they met all the milestones for the things that we're looking for to look for chronic disease? Have you had a mammogram? Have you had a colonoscopy? Are you getting your annual flu shots? Have you had a vision exam? Have you had a hearing exam? That's what the annual wellness does. There's a separate charge for that, which is separate and apart from the visit for, I need my prescription refilled. They can take place at the same time on the same day, but they're two different notes. They're two different billing codes that need to be used. The annual wellness visit is where we want people to start checking for dementia and screening for depression and screening for dementia. So what are the screening tools? Simple things that doctors don't have to do, but the CNA, the LPN, or even the office assistant can administer. You'll see a number of these things, the mini-cog, which is the clock drawing test and a 3-item recall, mini-cog with a functional assessment questionnaire, the Montreal Assessment Cognitive Assessment Tool, which is really too involved for this group, geriatric depression scale, or the PHQ-9. I've got forms of that for those of us who are doing that. Once you do these kinds of screening things in the process of conducting your annual wellness exam, when you note that there are things that need to be done and somebody doesn't perform well on your memory screen or your depression screen, then you have an E&M code, a 213, a 214 examination that is now required. And at that visit, this is when you start to look at these comprehensive things. This is where you order these things, not during the annual wellness visit. So you need a comprehensive medical exam to make sure that everything metabolic and physiologic is where it's supposed to be. If that all checks out, you're probably going to have some kind of brain image. Well, what kind of brain image do we like in neurologic assessments? We like MRIs. We don't want CT scans anymore, but I know people have pacemakers, but it's an MRI that they're looking at. What are some of the metabolic tests that we need to check for? Anything that can cause a problem. Thyroid, abnormal thyroid function, hypo or hyperthyroidism, poorly controlled diabetes, poorly controlled cholesterol, vitamin levels, and a syphilis screen. We do still have syphilis, and in appropriate populations you may want to do an HIV test. That is coupled with neuropsych testing, which I like to say is the learning test or the IQ test for seniors. You know, when we have children that have disabilities, we send them to a neuropsychologist to figure out what's wrong with them. You know, do they have ADHD? Do they have some other kind of learning disability? Well, we send them to the PhD doctor for a pen and paper test to measure what kinds of problems your brain is having. What kinds of information are you able to process and not process. And in the course of neuropsychologic testing, a lot of times we also pick up on depression. And again, depression is something that can be treated. Okay, what is the amyloid cascade hypothesis when it comes to Alzheimer's disease, not vascular? It's sort of like, again, the accumulation of these amyloid plaques in your brain. Cholesterol kind of contributes to that, but these amyloid deficits cause the brain, the nerves in the brain not to function. So research and treatment is to be directed toward preventing this amyloid accumulation, which is where we are now with respect to research. Biomarkers, this is part of the evaluation that you'll get if you come to the Emory Cognitive Assessment Clinic, because in addition to all those things that I talked about earlier, we do a lumbar puncture, which means you get a spinal tap, we stick a needle in your back, and it's not as horrific as when you had an epidural or the kind of spinal taps you had in the 1960s. It's just like taking blood from your arm. I don't like getting stuck, but it doesn't hurt any more than that. Again, I know that's subjective, but I'm a real weenie, and I do them, and it's no worse than getting blood from your arm. And what are we looking for? We're getting the cerebrospinal fluid to look for these precursor proteins that cause amyloid to develop. Okay? Now, what happens if we find this? Right now, cerebrospinal fluid biomarkers are emerging as one of the key tools or tests for evaluating somebody with Alzheimer's. Cheaper than all the things that I mentioned before. If you have certain levels of these proteins in your cerebrospinal fluid, we can mark or indicate that you are at risk for developing Alzheimer's. Finding this in your cerebrospinal fluid basically gives you a diagnosis of Alzheimer's independent of anything else. Alzheimer's, not the other kinds. Okay, so how do we treat any of the dementias? Well, there's no known cure for brain degenerative disease. So all the dementias, remember my pie chart and all the other things that I talked about, there's no cure for any of that. Most of the medications we use to treat these things treat the symptoms only. Everybody knows about cholinesterase inhibitors. So what is that? That's the Aricept. I'm going to use a brand name because most people know that. The Exelon patch. People are very proud of the patch. They don't know the name, but they know that they're on the patch. And then Razidine or Galantamine. Those are the trade names. You need one of those, and it doesn't matter which one. It's the one that works best for you and the one that your doctor likes best, the one that you tolerate best. And you'll probably be on that medication for quite some time. Most of the research studies for people with diagnosed Alzheimer's require that you be stabilized on these medications for at least 3 months. If your dementia progresses, memantine or Namenda may be added as an adjunct to help with that. Again, none of that is a disease-modifying medication or combination. Those modify some of the symptoms and the behaviors. People with dementia, regardless of etiology, are likely going to be placed on an antidepressant. The SSRIs are the antidepressants of choice because they have the fewest side effects. What these medications do is help control behaviors. Maybe it's crying all the time. Maybe it's a certain amount of agitation. And it's not nearly as caustic as the next group of medications, the Risperidals, the Seroquels, the Geodons, the Abilifys. Most people who are on this latter group, the Risperidals, the antipsychotics, the atypical antipsychotics, are the people who are answering the door with the gun. They have some schizophrenia, they have some paranoia. And a lot of times with people who have mental illness, dementia presents, and they have more of those behaviors. So the interventional medications that are being developed but are not yet available fall into this class of what we call monoclonal antibodies. The first one is called bapineuzumab. It doesn't really matter. It's no longer in development. It's no longer being investigated because it failed. The next medication, solanezumab, is currently in phase 3 trials. And about 2 months ago, they indicated that they changed the endpoint. The endpoint for the disease was if you got it to a person who had early stage Alzheimer's. And these are all for early stage, not late stage, not for the 95-year-olds, but for the 60 to 65-year-olds who are still managing in the mild cognitive impairment age. The cognition didn't improve with trials to this point. So now they're interested in maintaining function, which is your ability to get up and mobilize and take care of yourself. We're not looking for changes in cognition. The next class of drugs is beta amyloid gamma secretase inhibitors. This inhibits the enzymes that cause the amyloid protein to develop. And it's an immunotherapy that's still in research. It's not commercially available, but people who go to an Alzheimer's disease research center may be involved in a trial for one of the last two. At our Alzheimer's disease research center and around the world, we are repurposing medications for the management of dementia. Strattera, or atomoxetine, which is a drug used for people with attention deficit disorder, is being looked at as excuse me, a disease-modifying drug for Alzheimer's type disease. And its mechanism of action is to reduce the inflammation that's associated with neurodegenerative processes. So what is the algorithm for dementia assessment? I'm not going to really go into this, but for those of us who are healthcare providers, I do have an algorithm that I want you to look at. And on that particular algorithm, on the first step in terms of evaluating, and this is for our providers, but for those of you who are bringing a relative to a doctor or advising your patients to get to a doctor, we need to make sure that they have a good medical exam. We need to make sure that the behaviors that we're looking at are not related to the fact that they have an untreated urinary tract infection or pneumonia or a metabolic disturbance. That needs to be the first thing that you do. The number one thing that causes behavioral problems in patients with dementia is a urinary tract infection. That's usually the thing that ignites the 911 call, the ambulance ride, and the use of all these extra things. There are other things that go along, but for those of us here, having worked, the last time I was here at the clinic, I had a patient, she was really sweet, who came in with her husband. They spoke Portuguese. Of course, I don't speak Portuguese. And my friend over here learned how to do a mini-cog, didn't you? Okay, now why do I like the mini-cog? I'm just going to say it's a clock drawing test. And it's probably the easiest thing for those of us working with populations that don't speak English to do. You draw a circle or give them a pre-printed circle. It's called the clock drawing test. This is the easiest one. This is something that I think people with all different ethnicities can do. The idea is you create a clock, tell them to put the numbers on the clock. Okay. Now why am I doing this? Because I'm going to tell you what you're supposed to be looking at. Okay. Now all those numbers look right, right? Okay, you see 1, 2, 3, all the way up to 12, right? If you're doing a screen, if you have a relative, they should be able to draw a face of a clock for you, because most of these people didn't have digital clocks, and they should be able to put the numbers on the clock. What are we looking for? We're looking for registration. Do you have all those numbers in the right place? Are they in the right position? You know, is the 12 and the 6 going north and south, east and west? Do you have the 9 and 3? And are the numbers right? Okay, the next thing is, okay, let's do a shorthand, longhand thing. Okay, make it 10 minutes to 2. Okay, 10 minutes to 2 or something like that. Did they put the hands in the right position? Nobody really does that part anymore, but if they get them approximately right, I give them credit. But But anybody who has a clock that goes 12, 10, 20, 30, 40, or puts all the numbers on one side of the clock, if there's anything wrong with that clock, that means you need to have some kind of further evaluation. Is that clear? Okay, so that's one that we can translate into other languages. That's the simplest screen that I can find for you. That's the simplest screen that most people recommend. And this is because it's easily translatable to different languages. Anything wrong with the clock, whether it's the numbers being placed, the hands being placed, or the quadrants. Okay, that's visual spatial orientation. People don't know what quadrants to put the numbers in. Anything wrong with the clock indicates that that person probably needs further evaluation. And those of us who are seeing patients have to get proficient at such things, and those of us who have family members we're concerned about, you can do that at home, right? Okay, I did something wrong. Okay. So I have a handout that goes through the different screening tools, and that's, again, not for everybody, but certainly for the providers. And Kristen, would you stand up, please? Kristen is our assistant from our outreach department, and she has screening tools for those of us who are providers and need the algorithm, and we can work through some of that. And she also has a goodie bag for a lot of information that talks to you about our Alzheimer's Disease Research Center here at Emory. We are one of 29 NIH-funded centers in the entire country. We're the only one in the Southeast. So we have studies for people who are normal, over the age of 50 like me, and most of the people in here, and we have the healthy aging study that is in development, and it's kind of like creating a longitudinal registry for those of us here in Georgia to study normal aging and the progression of brain function or dysfunction as somebody ages. So the idea is that every year you're going to get to participate in some kind of phone screen. So in our bag, there it is. For those of us, I'm going to explain what's in here. This is the community engagement piece, that's me, that basically goes out and explains things to people. You have a brochure in here. We have Doctor's Day coming up in September. This is a continuing education event for healthcare providers, licensed providers, physicians, PAs, nurse practitioners, and nurses. We gave it the first time last year, but we're bringing it again this September. So if you have a healthcare provider, a physician medical group in particular, we want you to come to this particular educational event. And then the last thing is this fancy little brochure here with my pretty face on it. This is what I like to call our menu, our options for what you can get if you decide to come to the Emory Alzheimer's Disease Research Center. It tells you who we are, what we do, and most importantly, you open here, it tells you the research opportunities. Now what I like about this is it tells you exactly what we're doing, exactly what the study is, and you'll either meet criterion for this or you won't. And if you don't have Alzheimer's, that's not a study for you, right? If you are between the ages of 65 and above and you don't have problems with dementia, we have prevention trials. If you have a family relative who has a documentation for Alzheimer's, they are looking at you because you may be at risk for developing Alzheimer's. I didn't say the other dementias, I said Alzheimer's. In which case you would want to be in a prevention study because you'd want to be under surveillance and be first in line for some of those interventional treatments that I talked about, right? And that one is called the prevention trial here. It's called the A4 study. It's a 3-year prevention trial, and that's for people between the ages of 65 and 85 with no obvious cognitive impairment. And that's a good one. That's a moneymaker for those of you who are worried about it. And then it tells you about all the studies that are available for people who have a diagnosis of mild cognitive impairment. And then this is my favorite one. This is like the wellness ones. The cardiovascular studies at the VA on the back side. Neurovision, these are the easiest ones for all of us to be in. Research is showing that instead of doing all that big workup that I talked about, we can start looking at people's eye grounds and look for features consistent with amyloid development. And then down here we have studies at the VA, which I like because it promotes physical activity and prevention. We have a number of exercise physiologists and clinicians who are studying the connection between improved exercise and brain health. Just for your information. The best exercise to participate in that preserves brain health is cycling. It's an aerobic exercise. And the VA is doing studies on it. You can look at the age criterion. It's the one thing I got my Sunday school teacher to do, and he's all excited about it because somebody's getting him on a bike, he's getting measured, he's getting his blood pressure checked. So these are the preventive health studies. For those people under cognitively normal, it's a great way to be assessed, and it's, I like to say it's a way to augment primary care to get yourself taken care of. And with that, I'm done. Questions? Can I do that, Latrice, or are you going to do that? Yes, ma'am.
Have you found in your studies any connection between autoimmune diseases and, dementia?
Actually, that is a theory that's taking place. Those antibodies that I talked about, monoclonal antibodies, that's an immunotherapy. That has to do with the autoimmune function. Now, is it correlated with lupus or any of those other things? I can't tell you that. But I think that they are looking at immunotherapy as a preventative, just like we do flu vaccines to keep somebody from developing the flu, or pneumonia vaccines. That's an immune process. We're trying to change the immune process. But those are, that's research that's ongoing. And different places will have different studies that they offer. You can go to clinicaltrials.gov and ask those questions and identify studies that go along with that. Clinicaltrials.gov. The other place is the Alzheimer's Association has a website that allows you to pick research studies that you may be eligible for.
First off, thanks so much for coming in and sharing some of that with us. I was curious, have you done, I didn't get a chance to throw out your research, but are you doing any kind of research with how music can have a positive influence on
Now that's a very good question, because we actually have been working with, I'm going to say arts. We had this spring, we had a workshop called The Spirit Lives On, and we were working with visual artists who were working with caregivers and caregiving recipients. One was a painting class to see how people with dementia would respond, and the other was a photographic class for caregivers to take pictures of their relatives. But in terms of music therapy, A.G. Rhodes is leading a charge here for combining music therapy and horticultural therapy in terms of their overall therapy with persons with and without dementia in the nursing home. So music therapy is emerging as a therapy. I'm going to say therapy because it calms people. Okay, there is a technologic company here called Simple C that operates out of Georgia Tech that is also working with music and reminiscence for persons with dementia. So you might want to look that one up. They are working with music. Simple C. Just like I said, Simple C. Just look it up, do a website, and they can tell you about all their studies and all the interventions that they're doing. That's right here in Georgia. We actually, with our forum, have them exhibit twice a year, and we have people who are signing up, getting computers to help manage their family members with dementia. It's actually being very effective. So the combination of arts therapy, whether it's music or visual arts, is being looked at as a therapy to help manage the behaviors of people with dementia, but also to allow caregivers to spend quality time with their caregiving recipient. Excellent question. Other questions? Yes, ma'am.
I'm not currently a healthcare provider, but just on a personal level, what is the best way to communicate speech-wise with someone who might have pretty advanced dementia? I mean, in terms of simple sentences, repeating yourself.
Okay. The question is, what is the best way for a non-professional person to communicate with somebody who has advanced dementia? And I'm going to refer you to the Alzheimer's Association website because they have a tab under there that talks about managing behaviors. But I will tell you that the easiest thing is to speak in very simple sentences, one thing at a time. When you have a 2-year-old or a 3-year-old, how do you speak to them? You don't say, get up out of bed, go to the bathroom, and let's get ready for your bath, do you? If you want them to get out of bed, you say, Mother, let's get out of bed. And you say it and repeat it until she understands, and you assist her with that. Once she's up, you want her to do something else, then you advise her to do something else. But they're simple commands, and they're not things that are complicated. You know, more than one thing, more than one syllable that's hard for them to process, you'll frustrate yourself. It's like trying to potty train a kid who can't be potty trained. He's not ready, you frustrate yourself. Okay, one sentence commands. But check with the Alzheimer's Association, because they have an excellent page on managing dementia behaviors and how to communicate. And different centers will offer classes, usually by an occupational therapist who helps with managing dementia behaviors and helping you communicate and work with people who have dementing disorders. That's the job of an occupational therapist. Other questions?
Exactly can you tell me the connection between the UTIs and the dementia? I have heard of it before, I'm not a medical professional.
Okay, so what we're looking at when somebody starts to develop a urinary tract infection, that's a metabolic problem. Okay, so if you have a urinary tract infection, okay, those of us who are here, if you've ever had one, you know how bad that hurts, right? Okay, so if you have a bad urinary tract infection, you recognize the signs and symptoms such that you will call your doctor, you'll start drinking more water, you'll start doing something. A person with dementia can't tell you that their stomach hurts, so they'll start to do things. And what are the things that they'll start to do? They may refuse to get up. Their behaviors will change. They may not want to get up. They may not eat. They may just sit, or they may choose to lay down and not do what they normally do. In the course of doing that, they may refuse to eat. They may refuse to drink. And refusing to eat and drink leads to dehydration. Dehydration generally leads to a lower blood pressure and syncope, or passing out. And that's where we get the 911 call. Somebody comes in with a very, very low blood pressure, their skin, I mean, you know, clinicians, we pick at their skin, we try to see if it tense, but the most important vital sign for me is, what is their blood pressure? That's what I teach the medical students. What's their blood pressure? What's going on with them? Well, I don't know. Well, you do the obvious things. You check for things that might be wrong. But urinary tract infections, or any kind of infection in somebody with dementia, generally results in a change in behavior and a change in activity. And that activity may lead to a change in what they normally do, such that their vital signs change. If I'm refusing to eat or drink because I'm hurting, or because my stomach hurts, and if I feel better laying down because that's what makes me feel better, I can't tell you that's making me feel better, but I'm going to refuse to get out of bed. I'm probably going to refuse to eat or drink. And if I'm refusing to eat or drink, I'm going to get dehydrated, and it starts like a little vicious cycle. So making sure that you evaluate somebody who's had a behavioral change for a medical condition is very important. And that can usually be accomplished by having a frank discussion with your primary care doctor. And we always tell people to drink. And you know, older people don't like to drink, but they like watermelon. They like lemonade. You know, they like cucumbers. So you're not going to get your relative to drink a half gallon of water today. That's too much water. Old women don't like to drink water because it makes them pee all the time. Okay, but they'll eat watermelon, they'll eat cucumbers, and those are ways to keep people hydrated. You have to get creative. I discovered with my own mother, she wouldn't drink water, but my husband started making lemonade and limeade. I'm making him do that because he needs to work on his blood pressure. She's lapping up the lemonade. She's no arguments about drinking the lemonade. And that's a way to get water in them. But chopped fruit, summertime, springtime, chopped fruit, fresh vegetables, those are all things that contain water, and that's a way to keep somebody hydrated.
Going back to the slide that was how do we protect our brain and exercises on that slide, I was just curious, is there any research that shows a particular form of exercise, how many minutes, or is it?
Yes. They're on our brochure. We're talking about exercise, and you probably missed the discussion, but one of the exercises that's being indicated as one of the best ones is aerobic exercise, but cycling. How many of you do Soul Cycle or go to the YMWCA and do the cycling? Okay, at the VA they're putting you on bikes because that's the one that they have been documenting the best improvement. Why? Because it's improving blood-brain flow, okay? And aerobic, as opposed to anything like not yoga, not Pilates, aerobic, the swimming, the cycling. Okay, but cycling is emerging as one of the preferred exercises. And you can look that up. But at our VA Medical Center here, They are doing exercise studies, correlating exercise and brain blood flow, because dementia is a brain blood flow kind of thing.
What about eating? What about meats?
Okay, I'm not going to get into that, but what's the problem with meats? What's wrong with meats? What did I tell you was a risk factor? Cholesterol, right? Okay, so you've had the heart lecture, you've talked about this. I'm not going to tell you eat only beef, eat only chicken, eat only fish. I am going to tell you that dietitians like you to eat fatty fish. I am going to tell you that they like you to eat chicken or poultry as opposed to beef and lamb. Anything that you have ever heard about nutrition from a nutritionist, you have a registered dietitian here, right?
Yes.
Anything she tells you about good health, you need to do that. Okay, I want to do noni juice, I want to do coconut oil, I want to do coconut water. Horse crap. Cut it out. Okay? Drink the water, eat the vegetables. You got a nice garden down here. I'm going to make sure that you sell to your community, but then I'm going to buy up everything else because you have the best kale and onions. Okay? Allium, the onions and the garlics are really things that you should populate your fruit with. But on the subject, and I'm glad you brought it up, of nutrition, what should we do as nutrition? How many of you are familiar with myplate.gov? Okay, where's my nutritionist? Stand up here. Okay, this is somebody that you really need to pay attention to. If you develop hypertension, you can't will it away and do better by doing natural things. You already got it, you got to take the medicine. But you got to do MyPlate. You have a plate, cut it in 4. Half of it should be green, leafy, and colorful. One part of it, if you're going to have a meat protein, whether it's fish or whether it's beef or whether it's chicken, shouldn't be bigger than your fist. I saw some of us load up our plates with those chicken fingers. You didn't take 1 or 2, you took 5 or 6, and you have a mound here. There's something wrong with that, okay? Because not only is there a mound there, it was a mound of fried chicken. We're in the South. I love fried chicken. I'm not going to tell you you can't eat it, but you have to use some of your own judgment, your own discretion, because you've been told that fried fatty foods are bad for you. MyPlate.gov, make a picture. Don't get a platter. Don't go to the buffet table. Get a salad plate, okay? And studies have shown, now this is a small salad plate, but studies have shown, okay, the little paper plate we got here, this is more like a salad plate to me, okay? You got a salad plate, hold up your little salad plate, cut it in 4s, at least a quarter of it, but make a half of it colorful. You know, I put all my green stuff on top of my lettuce to make sure I have half a plate of something. Okay, use MyPlate. Use your dietitian. And I don't want to hear somebody sold you coconut water, coconut juice, resveratrol, noni juice, or something else. That's a way to dissect your wallet. Got it? Water is free for the most part. See your nutritionist. Thank you.